So we are pleased, very pleased to have today with us in our Bar Ilan University Vision Science Seminar, Dr. Sharon Gilad-Gutnick from MIT. Dr. Gilad-Gutnick is a staff scientist at the Brain and Cognitive Sciences Department at MIT. She did her BSc at UMass Amherst, I hope I said this, the name of the university correctly, with her honors thesis done on mechanisms on face perception at Professor Pawan Sinha's lab at MIT. During her BSc studies, she met Pawan, then a young assistant professor at MIT, and she was extremely excited to work with him in a summer job together with Dr. Antonio Torralba when the idea of Project Prakash just started forming. She did her master's at the Weizmann University of Science at the Departments of Life Sciences and Applied Mathematics under the supervision of Professor Shimon Ullman, where she worked in comparing and contrasting human and machine vision algorithms for subordinate face perception. She then traveled to India and Nepal and worked on action and intention recognition for a couple of years under the joint supervision of Professors Dov Sagi and Shimon Ullman. She was awarded her PhD from the School of Psychological Sciences at Tel Aviv University, where she investigated configural face perception under the supervision of Professor Galit Yuvel. She then returned to Pawan Sinha's lab to work on Project Prakash as a postdoc fellow. Today, she's a research scientist at MIT, and on top of being a consultant for a couple of startup companies, she spends most of her time on her research at MIT. Her expertise lies in integrating behavioral and psychophysics data with imaging and computational approaches in order to probe visual learning mechanisms, such as those driving face recognition. And she does that through extensive work with children and adults with normative and abnormal visual development. So without further ado, welcome, Sharon, to our seminar. We're delighted to have you with us today to hear about your research.
Hi, thank you so much for having me, and thanks for bearing with me as I figure out how to share my screen on Zoom. You'd think that after a few years I'd have this figured out, but okay. So today I'm going to present some of my work on Project Prakash, specifically work on the emergence of face perception in these children that start their visual journey late in life. So, okay. So I'm just going to give a little bit of background on Prakash. I don't know exactly what background the people that attend have, so bear with me if this is things that you've already heard. So what I hope to share with you today is some of the research that I've been doing as part of Project Prakash, which was born out of the realization that there's a huge humanitarian need. Oh, for some reason, I'll do it this way. That there's a huge humanitarian need to alleviate treatable childhood blindness. And I'm sure many of you know that the situation is particularly difficult in India, where the sheer numbers and prospects of children growing up with blindness is very grim. And there are many amazing organizations working on this mission, but part of what became quickly apparent is that in India, there's a significant population of children that suffer from congenital bilateral blindness, particularly due to cataracts, and that these children are going through their life without having any visual input, despite a relatively easy and affordable treatment for their condition. I hope it's not weird. I have you guys on a different screen, so that's why I'm looking sideways. So it's this need that gave life to our project, this pressing humanitarian need to treat curable blindness in children, but also an amazing scientific opportunity to directly address and recover some of the oldest and most basic questions about visual development, critical periods, and nature versus nurture. And it's through this dual humanitarian scientific calling that Project Prakash was founded in 2004. And today we have a team and infrastructure through which we've screened over 43,000 children, or children and young adults, provided non-surgical treatment for over 1,500, and surgically treated over 500 children and young adults. And so we do this through a highly collaborative and integrated effort of the three arms of our foundation. So a team of field workers and eye care specialists organize outreach camps in the most rural and overlooked areas of northern India. In each of these camps, hundreds of children are screened for any existing eye health issues, and if need be, they're provided with refractive correction, eye drops, or referral for further care. And it's in these camps that our team is also on the lookout for any child that has treatable blindness, and therefore a candidate for participation in our research program. Though I'd like to emphasize that no child is ever refused treatment, regardless of whether they or their caretaker would wish to participate in our research. The children with treatable blindness are then brought into a hospital in Delhi that we've been working with for almost 2 decades for further assessment and treatment if possible. And throughout this entire process, our research team works closely with both the outreach and medical team to clearly identify and assess the visual status of these children that may be a good fit for research, which broadly speaking means treatable, congenital, so from birth, bilateral blindness. And so our high-level research goal is to understand if vision develops. In other words, can a child blind for several years since birth benefit from optical correction for the eye? And is the brain at this point plastic enough to make sense of this information that's coming in from the eyes? Now, as you probably all know, there's a huge body of literature suggesting that visual learning is subject to critical periods. In other words, what this literature suggests is that if the brain doesn't receive appropriate visual input early in life, then past this period, the brain would be unable to make use of this information. But much of this literature has been performed on non-human animal studies, includes a lot of monocular deprivation, which is qualitatively different than full deprivation, has limited durations of follow-up and a small set of behavioral assays. And so many fundamental questions still remain open, and our work with the Prakash children affords us with the unique opportunity to answer many of these questions. Now, before I start, I'd first like to take a step back and just say that while many of you have probably heard of Project Prakash and the work that we've done, we're actually finding that outside the research community, we still need to reach the right people to make sure that these children are identified and treated. So those of you that have heard us present our project throughout the years often come to me and say, okay, now you've shown that vision can still develop on different aspects. Why are you kind of continuing this project? And of course, there's the research questions that are still left open in terms of what skills develop and how. But the thing that's really interesting is that I've presented this work quite a few times to clinicians, primarily ophthalmologists that are out in the field identifying these children around the world. And they still question the idea that children with blindness since birth should be treated regardless of age. So we're still finding a lot of ophthalmologists that are out there in the field telling us that they kind of have this rule of thumb that when they see children where they suspect that the blindness has been there since birth and they're past critical age, they actually don't treat them. So we really want to be able to reach these communities. And just to give you a sense and an intuition of the importance of how much vision can actually improve, I'd like to share a quick video to show you that regardless of what aspects of improvements we can capture through well-controlled lab studies, it's clear that these children can really benefit in their daily activities from the onset of sight. So this is AR. She's an 11-year-old girl. And what we're seeing is a video of her only an hour after sight onset. So an hour after her bandage was removed. And you can see that Pavan is asking her to follow with her finger the moving train. And if we looked at this in a really nuanced way, it may be that she's not performing this as well as controlled children, but without really any visual experience and just immediately after treatment of one eye, you can see how well she's doing with so little of visual experience. And of course, you can see how proud she is of herself. And that's something that we really see across the different children. They become very proud and very confident quickly. Okay. There we go. So I think everybody can agree that vision definitely develops, but a big question is still what skills develop and how. So what information is the brain using to make sense of the visual world following extended visual deprivation? Now, I'd like to take a step back and just say that we're definitely not the only lab doing this. Particularly, I think in the past decade, there have been quite a few amazing labs that have engaged in this type of research. And obviously, I don't discuss their findings here. And I haven't looked at the audience. Some of these people may be here, so feel free to ask questions or bring things up as they become relevant. But it's definitely worth looking at the work from other labs. And I think that the past few years have really brought on a collective effort to better understand what skills develop in these children and how. Okay, so just, quickly about myself. In the past few years that I've been working on Prakash, I've primarily focused on 2 lines of research, focusing on visual learning following early visual deprivation. The first line of research focuses on face perception, and I'm really trying to take a holistic approach of looking at different aspects of how the face system develops within the same child, so how different skills develop within the same child. And I focus on the role of early visual acuity trajectory. So some of you may have seen our work on high initial acuity. I'll mention that later. Unfortunately, I'm probably not going to get to it this time. The second line of research that I have focused on in the last few years has been on the development of graphical representations in these children. So basically how their drawing abilities change as soon as they gain sight and with visual experience, and what this might tell us about their internal representation of the outside visual world. And for both of these lines of research, I'm particularly interested in the role of temporally changing information or dynamics. And in this talk, I'm going to focus on the development of face perception, of course. I'd love to be able to tell you about the drawing work on another occasion, and I'm actually supposed to present that in the plasticity and multisensory seminar in the fall. So hopefully, if you're interested, you can attend that. Now, to give you a sense of why I'm so interested in the development of face perception in this population and the combination of methods that I use, I'd like to tell you about an experience that I had with a boy that I met back in 2018. So this is Z. He's an 11-year-old boy with congenital bilateral blindness. Our research team met him and his older sister that you can see here, and was also congenitally blind, at a residential school for the blind that they attended. Our team brought him and his sister, as well as 4 of their peers, back to Shroff, a world-class eye hospital that we've been working with in Delhi. And despite their vision being extremely compromised, Z overall seems well-adjusted, confident, and social, and he obviously has a very beautiful smile. So Z was treated, and like all the other children that we've seen, he seemed to bounce back almost immediately. He and his friends are sensory, but they're extremely curious and intelligent. And like many of the kids, they open up and they gain confidence quickly after treatment. In fact, as you can see, after surgery, the children begin to confidently navigate around the hospital, socialize with peers, respond to and appropriately orient toward others, and most inspiring, they are constantly and actively seeking experience and to learn from the visual world. And this often actually requires our attention. So sometimes they become a little bit too mischievous, like here, where one of the children started building a structure with our research cameras, kind of throwing off all of our research. But these children are so brave and so curious that it's really a pleasure to watch them grow and learn. And I have to say, and I'm sure that Shlomit, who's in the audience, can echo this, we really get to know these children very well. And they, I mean, my kids know them all by name. They kind of become an extended part of our family. Now, Z is a little bit different than most of the children that we've seen through the years because he has some pattern vision prior to treatment, and certainly seems to have a lot of functional vision after treatment. In fact, even before he came in for treatment, his parents indicated that he's able to navigate independently around the school and to some degree even around the village. And if you observe him in his naturalistic setting and interact with him after treatment, one would think that his vision and understanding of the world is actually quite reasonable. And of course, there are many ways in which we can assess this. So we can look at his acuity trajectory, and that's going to tell us a story of huge success, whereby even though he was treated at the late age of 11, by 4 months after surgery, he no longer qualifies to be legally blind, even by US standards. And this seems entirely consistent with his behavior. So here you see him just a few days after treatment, eager to show off his newfound skills. Here he's learning how to use a camera on a smartphone. So he snaps different pictures in the room, and then he proudly shows one of our researchers his pictures. And in this picture, our experimenter asks him what he sees, and he smiles and seemingly effortlessly points at and recognizes his friend B. And here's another picture that he took, and just as confidently, he points and says, "That's B." And so it seems like Z is actually relying a lot on colors and compensating greatly by showing confidence and assertion in his answers, which is something that we can see quite often. And yet he's confusing a bottle for his friend, right? So he's making a mistake that most of us would assume even a baby wouldn't make. And for me, as someone who has spent many years studying high-level vision and in particular face perception in the lab and under controlled conditions of psychophysics, his behavior is particularly interesting. So watching him in a naturalistic environment, one would really think that his vision, and in particular his ability to recognize and interact with peers, is actually quite good. And this is an ability that, as neuroscientists, we spend a lot of effort studying because we believe that it comes on earlier than other abilities and that it's particularly robust. And it's a basic ability that's really critical for development and learning in general. And Z does seem to be doing well with it, except he's really not, right? So it's quite important that we use complementary approaches in our work. And that's what I set out to do a few years ago, which was to determine and compare how well these children do, if at all, on different dimensions of face recognition under both naturalistic and standardized lab tests. And to better understand what this tells us about how face processing can develop at a late age after extended blindness. And I'm going to try to take you through some of that journey, kind of going back and forth between the naturalistic, more anecdotal evidence, which we at some point implemented as a more standardized protocol, versus more like gold standard psychophysics tests of face recognition. So the three aspects of face perception that I've looked at over the last few years, all from a developmental perspective and as much as possible within the same child, were at how faces develop as a category, how facial expression recognition develops, and how face individuation or identification develops. And I'm going to focus on the first two just for the sake of time. I'll kind of give you a teaser for the third at the very end of the talk. That's work that we're writing up for a special issue and submitting next month, and I would love to present that at another time, but I just don't think we'll get to it today. So focusing on concept formation of faces, in other words, face detection, we specifically want to ask if and when brain and behavior show face-specific responses as a function of visual experience. So as I showed you from Z's case study, children with early prolonged visual deprivation might not be as good at even the basic face perception tasks as they seem to be through anecdotal observations. So we can probe this question of when they're able to identify a pattern as being a face by asking further whether this ability can even be learned after extended deprivation and what information is used to form this concept. So this first study is a little bit older. It was spearheaded by Tapan Gandhi when he was a postdoc in the Sinha lab. He's now a professor at IIT Delhi and continues to work on Prakash. So Tapan used a well-known face classification algorithm to collect a set of images consisting of 4 categories: true faces, which were correctly identified by the algorithm as face images, true non-face images, so these are images that were correctly identified as non-face images, and images that are increasingly similar to faces. So these are images that are non-faces, but were incorrectly identified by the algorithm as faces. And for each of these, he basically just presented them to the child and asked, is this a face or not? So first I'm going to show you data from age-matched control children. with typical visual development. And just to take a step back, let me explain how we run control studies in Prakash. And this is going to be a recurring theme or strategy that you'll see across all the studies that I present. So while most of the Prakash children show significant acuity improvements after treatment, the degree of their acuity improvements is still really difficult to predict. And importantly, all these children will still suffer from some acuity impairments. So we basically know that while acuity can and does improve, there's definitely an early critical age, and these children will never reach 20/20 vision. So in all of our studies, in order to tease apart which improvements or lack of improvements are due to the deprivation of visual experience in the first years of life versus those that are due to their suboptimal visual acuity even after treatment, we run age-matched control children who have typical visual development, but we have them perform the tasks while viewing the world through blur filters. So in other words, they perform the tasks under imposed visual acuity conditions that match the visual acuities of the Prakash children after treatment. So now back to our results. What we find in the acuity matched controls is that despite suboptimal visual acuity at test time, controlled children don't confuse faces from non-face images, regardless of how similar the images are to a face. In other words, they show this expected step-like pattern of performance, whereby all face images are correctly identified as faces, and all the non-faces are identified as non-faces. Next, what we want to know is how the cataract-treated children do on this task as a function of visual experience or time after treatment. So I'm going to show you the average data across subjects. As you can expect, prior to treatment, the children identify all the image categories as faces approximately on half the trials, meaning that they're completely unable to differentiate between face and non-face images.
Sharon,
Yeah.
sorry.
Yeah.
I'm just not like, you are administering this to them even though they're hardly able to see anything?
Yeah, so in general, what we do is that we try to run these children on these tests prior to treatment. Sometimes it's a shortened version of the experiments, just not to put the child through it. It's obvious that they can't perform a particular task, but on every task, we do try to run them prior to treatment if possible, so that we're able to actually say, yes, they weren't able to do the task prior to treatment. And you'll see also on some of the later studies, and kind of a recurring theme for my research is really looking at and trying to separate between children that have different pre-treatment acuity profiles, because even though all these children are legally blind and beyond, some might still have residual pattern vision, and we really see varying levels of how much pattern vision they might have prior to treatment. So they really won't be able to perform tasks like these. They might have some finger counting acuity. But what I'm really interested is trying to differentiate between, those children that can only see light versus dark versus some pattern vision prior to treatment, and whether that impacts or bootstraps any of these abilities later.
Okay, thank you. Great.
Okay. So we see that as these children gain visual experience, they do become better at the task. But they do seem to make confusions that are similar to the ones that the face classification algorithm seems to be making. So in other words, their performance is graded. The more similar an image is to a face, the more likely they are to confuse it with a face. But about 2 years after treatment, the children do actually achieve performance that's very similar to control children, and they no longer confuse face from non-face images, regardless of how similar these images are to a face. We recently published a paper where the data analysis was really spearheaded by Katrina, who's a postdoc in Bas Rocker's lab, and she did really amazing work looking at changes in white matter pathways. And I'm not really going to get into the details of this work, with the exception of how it relates to the emergence of face discrimination ability. So in this project, we assess behavioral performance in both visual acuity and face non-face tasks, and how it relates to changes found in white matter pathways. And what we found in general is that there is plasticity in the late but not the early visual pathways. But more specifically to the issue at hand, what we found was that the structure and organization of the brain's white matter appears to underlie some of the face non-face improvements that we observed in these children. Specifically, we found that the behaviorally observed improvements in face discrimination, but not in acuity, seem to be directly modulated by increases in the structural integrity of the posterior callosum forceps, which connects the bilateral occipital regions in the late visual pathways. So just wrapping up this section on face discrimination ability, we found that face non-face categorization can be learned even in late childhood, and hence it's unlikely to have strict critical periods. We further found that face categorization changes from a graded to a step-like pattern after sight onset, and that this relies on extensive visual experience. So it doesn't occur right at sight onset, but requires a lot of rich visual experience. And that these experience expectant improvements in face discrimination seem to be modulated by increases in the structural integrity of late visual pathways. Now, another question that seems fundamental, and Sharon, let me know how I'm doing with time also.
You're doing great. You've got another half hour or less, as much as you like. That's more or less.
Okay, perfect. And of course, I forgot to say this at the beginning, but if anybody has any questions, feel free to stop me. So another question that seems fundamental when we think about the emergence of faces as a category has to do with this kind of big, and I think still controversial question of whether faces are special, and if so, whether there's an innate bias towards faces or face-like structures. And I'm not really gonna get into this huge body of literature, but I think everyone here is probably familiar with this basic kind of idea that even newborn babies will tend to have more head turns or looking behavior towards face-like structures compared to scrambled faces. Now, some of the more recent studies that address this question in a bit of a more nuanced way is this great study from Margaret Livingston's lab. So they raised monkeys that were face deprived, and then they measured their free viewing looking patterns once they were introduced to faces. And what they found is that while the control monkeys did look disproportionately more towards faces, the face deprived monkeys did not look preferentially at faces, and instead they looked more often at regions containing the hands. And around the same time that they performed this study, with a lot less efficiency in terms of publication, we performed a semi-naturalistic data collection session with the children immediately after bandage removal, where we had the opportunity to look at similar data in Prakash children. So this is kind of part of the bandage removal where you saw the child follow the train with her finger. An important differentiation is just to say that our children were not specifically face deprived, but rather they're visually deprived in general. But here you see with our very own Shlomit Ben-Ami, AL, who's the 7-year-old sister of the child that you saw following the train. And Shlomit is, of course, part of this project that we're still working on putting together. So I'm going to show you a video taken from a scene camera of the head-mounted eye tracker that AL was wearing. So the children, their bandage is removed, they're fit with an eye tracker, it's calibrated, and then we do this kind of semi-controlled task where they do different things, and a lot of it has to do with free viewing and looking at different people who we kind of try to control for how these people are dressed so that the faces really provide the visual information that the child would need. So this video is taken within 20 to 30 minutes after sight onset or bandage removal. And what you'll see is her gaze as she tracks the scene. Here we go. Okay, so you can see that they're asking her that you have 4 people standing in a row. All of these are people that the child is extremely familiar with. She's been living with them for the past couple of weeks. They're all dressed the same, kind of trying to keep their expression neutral and not move. And we ask the child different questions like, you know, just look around. Can you recognize who is your mother? Can you recognize who is a male here? And so on and so forth. And I'd like to note that while it seems like it's possible that what's happening here is that the child just has this like general downshift or is keeping her head down, or maybe the eye tracker isn't really working properly. And we did see this across different children with kind of different levels of pre-treatment acuity profiles and different levels of improvements. What we did see also is that when the child is cued to look at the hands, she does. When she's cued to look at faces, she does. And when she's asked face relevant questions like which person is your mother, she's able to kind of look up and scan the faces, but she really needs some cueing. And so it doesn't seem like this is really a problem with the eye tracker, this downshift that we're seeing. A few days later, I don't have that video here, but a few days later, the child is able to recognize her mother from approximately this distance, pick her out from the 4 people, but she still has this strong bias towards the hands, and unless she absolutely needs to, she looks down and specifically looks at the different people's hands. Whereas about 6 months later, she's much more self-guided in terms of looking at the faces, but we're still quantifying whether that's the same as controls or not. So what we're seeing is that our children definitely don't seem to have a face bias right away at vision outset. They know what a face is. They look at a face when they're cued to look at the face. And they definitely show the strong bias towards looking at the hands. And this is kind of surprisingly consistent with Livingston's findings with the face-deprived monkeys. And I'd like to just note that you know, a big caveat is that it's difficult to compare newborn studies and findings to the findings in our children, because obviously the visual experience or lack of visual experience can actually shift the strategies, the looking strategies, even in free viewing of these children, to rely on other cues. So these results can't necessarily inform our understanding of newborn neurotypical development. But Margaret Livingston's study, which I would definitely recommend for people to read if you haven't seen this study, does bring up some interesting ideas about why the face-deprived monkeys are more biased to look specifically at the hands compared to faces. And I think that a lot of those ideas can directly translate to what we're observing in the Prakash children. And if anyone wants to talk more about this later, I'd be more than happy to. It's something I'm pretty interested in. So the final question that we want to ask in the context of like, do faces emerge as a category, is to see whether cortical specialization for faces develops in these children. So do we see stereotypical cortical specialization specifically for face-related representations? So to better understand if and how face-specific representations develop after late sight onset, we can use simple face non-face contrasts. In other words, we can throw our children in the scanner, have them passively view face and non-face images, and then at different time points after sight onset, we can see if the areas light up in response to faces more than non-face stimuli. And that's what we did. So this again is data that was collected quite a while ago and is just about to be published, spearheaded by Tapan. And what I'm going to show you is data from one cataract treated patient who was 21 years old when he was treated. So this is actually a young adult. And we're looking at activation patterns for faces greater than objects. And what we're seeing is that while prior to treatment, we don't see these face-specific activations light up, by 10 months after treatment, we're seeing face-selective responses emerge and really be very robust. And we see this across many children. We already have this data analyzed across a number of children who were different ages when they were treated. But so this is really interesting, and it's really wonderful. But looking only at the emergence of the FFA in simple contrasts, for me, is kind of not sufficient. And like I told you before, I'm specifically interested in motion and in general understanding visual learning that's rooted in more functional and naturalistic conditions. So luckily for me, people have done some great work in the past 10 years on kind of mapping out the neural mechanisms that support face recognition and increasingly conceptualizing them as this distributed and well-integrated system, as opposed to just a set of individualized, specialized regions. So this distributed face network spans dorsal and ventral streams, and we're making good progress in understanding more about how these areas interact to support a range of face recognition abilities. But to just oversimplify, and I know there's some controversy on exactly how the two pathways differ in terms of what they represent, but just an oversimplification is that in general, what people have found is that there's this division of face processing network to a dorsal, more motion sensitive stream, and a ventral stream that's not sensitive to motion. And at a basic level, the way these different areas are mapped is by using these face non-face contrasts, similar to the one that we just saw, except now we add faces in motion, or dynamic faces, and objects in motion, or dynamic objects. Now, I was even more fortunate because when I was interested in this, I had the help of the same people that empirically characterized this network in designing the study. So I just want to give a big shout out to Dorit Yovel and her then student, Noah Sinkri, who helped me really think through the study design and shared the stimuli and protocols. We're currently in the process of analyzing this data. So Vasiki, who is now doing her postdoc, started analyzing this data when she was a PhD student at Dartmouth in Ida Gobini's lab. So I've really had the best people supporting me as I work through this complicated data set. And we had a pause in this, but Vasiki is back on track to continuing the data analysis. So we're pretty excited about this. Now, what I'm going to show you is, in orange, I'm going to show you activation, and in blue, I'm going to show you deactivation. So in the ventral view, we see that the child starts out without any face selectivity in the ventral areas, most associated with representing faces. But over the course of 11 months, we see this kind of beautiful and increasingly large and robust FFA, or face-specific response, emerging, regardless of whether the faces are shown in motion or not in motion. When we look at the dorsal view, we see this widespread activity that becomes more localized to the stereotypical face selective areas. So we're seeing these face selective areas emerge, but more in widespread activity that becomes more specialized, as opposed to what we saw in the ventral view. So when we take this data together, what we can see is that for this child, by 11 months post-treatment, all the stereotypical face selective patches of the network seem to be emerging. And we're even seeing some of the frontal person knowledge areas light up. So we're pretty excited about this. We've started data analysis already on a couple of other children. We've seen that these results seem to be consistent. And now what we're working on, we have data on about more or less 15 children, not fully complete data for all of them, but more or less 15 children, where we're hoping that with kind of the higher power of multiple subjects, we'll be able to determine which of these areas actually comes online first and may drive the type of information that's represented in other areas. So we're hoping to start to look at the different connections and the kind of developmental trajectory of these different areas in the full network. So do we see stereotypical cortical specialization, specifically for face-related representations? We do. In fact, we see the emergence of the entire distributed face network system. And hopefully, with the additional data, we'll also be able to look at the interaction and the temporal emergence of the different areas. Okay, so just to kind of give this interim summary for the high-level question of do faces emerge as a category, and how do they emerge? What we found is that children with extended congenital blindness can't differentiate faces from other patterns immediately after sight onset, but they do quickly begin to categorize faces as such, despite the extended and early visual deprivation. Face categorization transitions in these children from graded to categorical. And unlike acuity improvements, the face categorization seems to be modulated by changes in the integrity of white matter pathways in the late visual areas. Finally, we see that there doesn't seem to be a face bias immediately after sight onset, despite knowledge of where to look at and despite looking when cued, but there does seem to be a strong hand bias. And we see cortical specialization that we expect to emerge, and the entire distributed face network emerging quickly, but this requires also extensive visual experience. So does anyone have any questions before I move on to facial expression recognition?
My thoughts are that maybe we will keep the questions for the end.
For the end?
I mean,
Okay,
yeah,
sure.
I mean, unless there's some technical issue, people are not.
No, that works.
Okay, lovely. Thank you.
Okay. Okay, so now I'm going to move on to kind of a more downstream aspect of face processing, specifically facial expression recognition. There are studies out there in children with early but much more brief visual deprivation, so 2 to 10 months of visual deprivation, where researchers have shown that even though these children had very brief visual deprivation, when tested many years later, they're able to perform well on basic facial expression recognition tasks. The same lab of researchers in a follow-up study did show, however, that these children seem to perform the task differently than controls. So they have different response patterns when tested on a finer grained facial expression recognition task. But there are still foundational questions that remain unanswered with regards to how facial expression recognition emerges. So what we really want to ask is whether facial expression recognition acquisition is still feasible following early onset visual deprivation that extends well beyond the putative critical periods of development, which is kind of what we can answer with our population. And we also want to consider what type of cues may play a role in extending the window of visual development. So we're specifically interested in the role of motion and the role of prior pattern vision. And I want to make sure just to emphasize all these projects obviously require collaboration from a lot of people. This work is currently under review, and Grace Korean came to us from Micah Murray's lab just for a summer as a guest student and started working on this data and has continued remotely working on this data with me and did really a great job with the analysis and the write-up. So our task is a basic 4 alternative choice task where subjects saw a cross followed by a face stimulus of an actor performing one of 4 facial expressions: happy, angry, fearful, or sad. And the subjects saw either a video, either a 2-second video or a 2-second image displaying one of these 4 faces, and then one of these 4 emotions, and then they were asked to indicate which emotion the face displayed. Now, to ensure that all our participants are conceptually familiar with the 4 emotions that are tested, we had subjects participate in a short survey prior to the experiment, where we asked them to orally identify inappropriate emotional reactions. So for example, we said, how would you feel if you were attacked by a tiger? Fearful. And we also asked them to act out, what would you look like if you felt fearful or if this happened to you? And so we just kind of wanted to make sure that they have this proprioceptive information and that they have this basic understanding of these emotions. Okay. So we divided the patients, the Prakash children, into two groups. Those with visual acuity that is worse than that of a newborn, and those with visual acuity that's equal to or better than that of a newborn. So the idea here was basically, and choosing newborn acuity is not completely arbitrary, but I'm not going to get into the background of how we chose that cutoff, with the exception that it's certainly biologically motivated. So what we can do by dividing the children into these two groups is to look at whether residual or very coarse pattern vision early in the development provides a facilitatory effect for the development of expression recognition. And I'll say that even the children in the PN group who had equal or better acuity than newborns, I think we had one child with like 20/400 or 20/450, and all the kids were much more profoundly impaired. So here we see facial expression recognition performance on both the static and dynamic tasks for each of the three control groups. So in this case, we ran three control groups at three different acuities. Okay. And we also see the performance for the PA group in orange and the PN group in purple. So our data reveals a few interesting patterns. The first thing that we're seeing is that pre-treatment performances are different across the two patient groups, right? So basically, children whose pre-treatment acuity was worse than that of a newborn performed at chance on both the static and dynamic tasks, whereas the children whose pre-treatment acuity was profoundly impaired but still comparable to that of a newborn performed above chance on both tasks. So in other words, even extremely coarse visual acuity early on in development, so in the first few years of development, can allow some minimal level of facial expression recognition to emerge. But visual acuity worse than that of a newborn infant precludes the emergence of this skill altogether, regardless of cue type. So regardless of whether we're looking at static or dynamic faces. Now, a far more interesting question is, following profound visual deprivation in the first years of life, will the introduction of higher resolution visual information later in life still allow the brain to learn how to distinguish between these basic facial expressions? So we tested these children at least 3 years after sight onset. And what we see is that the children show significant performance gains compared to their pre-treatment performance. Specifically, we found performance gains for the PA group on both the static and dynamic tasks. And this trend was also present, but much less robust in the PN group, where we showed significant gains in the dynamic, but not the static task. Now, this is somewhat surprising that when comparing the two patient groups to each other, performance several years after treatment was also not significantly different on either the static or dynamic task. So the PA and PN group 3 or more years after treatment were not different from each other. So while the PA group shows overall larger performance gains than the PN group, the final performance achieved by the two groups is comparable, suggesting that despite the PN group having enough residual vision prior to treatment to establish some level of facial expression recognition, this early skill doesn't provide a bootstrapping effect for facilitating the emergence of facial expression recognition after treatment. Another notable aspect of our results is that even with extensive visual experience, 3 or more years of treatment, after treatment, both patient groups do continue to show significantly compromised performance on both tasks relative to their typically developing acuity matched peers. So you can see that 3 or more years after treatment, these are the average acuities of the two groups. They are not significantly different, and their performance levels don't reach the acuity matched controls.
Sharon,
okay.
Can I have one short question? Regarding the dynamics that you mentioned in the trials, are these dynamics directly related to facial expression change, or there are any dynamics, any kind of dynamics in the scene?
No, so they are related to facial expression change. So we use a validated stimulus set of videos, high resolution, kind of full color videos of different actors that go from neutral to a final expression. And then we either took just the final frame of those videos for the static condition, or we showed the entire video for the dynamic condition. And we obviously, they weren't overlapping, so that there's no perceptual transfer between the static and dynamic. But yeah, that's a basic setup.
And have you tested for the static images, if you can cue the subjects to the areas where this change is appearing in the dynamic scenes? So if you treat the dynamics as attention to these cues, what happens if you give these cues also for the static stimuli?
Yeah, so that's a really good question. We haven't tested them when we cue them, but I am going to show kind of this hypothesis that I don't have the data for yet, and this would be one way of getting at empirically getting at that hypothesis, in which I kind of suggest just that there might be these differences in performance might actually be due to differences in fixation patterns. So I'm going to get to that in a minute.
Okay, great, thanks.
Yeah. Okay. The other thing that I think our group kind of uniquely does is we really look at longitudinal progression of these children on these different tasks. So we bring the children back into the hospital every few weeks and then every few months in order to really see when certain skills emerge. So in mapping that out for the two patient groups, what we can see is that even though they began their journey with different pre-treatment performances, their developmental trajectory of expression recognition performance are mostly similar across time. In fact, over the first year since site onset, during which the children experience extensive and naturalistic visual experience, so they go home, they're not limited in how they view the world, the performance of both patient groups remains generally flat in recognizing both the dynamic and static facial expressions, suggesting that neither group really shows any improvements. But both groups do show improvements in performance gains when we compare them to the, when we look at their performance 3 or more years after treatment. So this final data point is the data point that you saw before. You saw before just the pre-op and this final data point. There is this big gap here, and unfortunately, this is COVID. So we kind of lost this period to see what happens between 1 year and 3 years. But I still found it to be pretty interesting that we don't see, there's no significant improvements from pre-op performance into any of these time points up to 1 year. And the significant changes only occur 3 or more years after treatment. So overall, it seems that regardless of the presence of residual vision that's meaningful enough to lead to some facial expression recognition even prior to treatment, the emergence of these mechanisms is constrained by early critical periods, leading not only to similar post-operative performances across the two patient groups, but also similar developmental trajectories in which any improvements that occur require more than a year's worth of rich visual experience. Now, to better understand the gap in performance between the control and patient cohorts, we also looked for effects of motion cues, so directly comparing the dynamic and static within each group to assess if they're using different cues or strategies for each task. So contrasting expression recognition performance on the dynamic versus static task, we can see that here. We see that the PA group show a strong dynamic advantage or superiority for recognizing expressions when provided with motion information, whereas the PN group and the 3 control groups don't show this effect. Of course, there's this one exception with the 20/500 control group, and I'm going to get to that in a minute. You'll see that that's actually driven by just a couple of outlier children. The next thing that we did is we defined this dynamic advantage metric for each participant. So for each participant, we calculated their dynamic minus static performance, averaged that within each group, and that's a dynamic advantage metric for the group. So what we can see is that the dynamic advantage found for the PA group is significantly larger than the one found for any of the other groups. So while image resolution can't really account for the robust dynamic advantage that we find in the PA but not PN group, we did want to further probe this issue. So here we show the individual subject visualization, and we confirm that the average differences found in the controls with the 20/500 acuity is driven only by a couple of individual subjects. Whereas the dynamic advantage found in the PA group is driven by the fact that every single subject, except one, performed better on the dynamic relative to the static task. And I have to say that for some of you, this may not be impressive, but our children, in most of our tasks, we get very variable results. And so for us, this was actually very impressive that we see such consistent across subject results. So overall, what we're really showing is that only the most profound visual deprivation in the first few years of life leads to the emergence of a robust dynamic advantage or superior performance in recognizing expressions that carry motion cues compared to those that don't. Okay, so this is kind of what we were looking at that led us to think about these different looking patterns. So beyond looking at overall accuracies, we also wanted to analyze the response patterns, because this can really be informative, obviously, about the specific strategies that subjects use during each task.
Sharon,
So the basic, yep.
Yeah, I just want to say we're at almost at 4 o'clock. So
Okay.
Yeah.
Okay, so let me run through this very quickly, and I think this is almost the last data slide that I have.
Sure, wonderful. Okay.
Okay, so basically what you can see here is just the confusion matrices of these of the patients and the controls at different acuity levels. And the basic idea is that if overall accuracy in two models or two subject groups is approximately the same, then looking at the response patterns might be really informative for comparing the strategies that they used. And so for the dynamic task, we saw that performance for the patients was almost identical to that of the group performing the task at 20/500. And when we look at the differences between the structure of their confusion matrices, we really find almost no difference. So they seem to be making the same choices as the controls performing the task at 20/500. On the static task, we found performance that was much lower, right, for the patients, and it pretty much matched performance of the controls performing the task at 20/1200. And again, we find that there aren't huge differences between the decisions that they make compared to the controls performing the task. So there seems to be this kind of discrepancy between the strategy that they're using when they're performing the dynamic versus static task, whereby it's almost like they're seeing the images as lower resolution when they're performing the static task compared to when they're performing the dynamic task. And so for the sake of time, I'm not going to super get into this, except to say that what this kind of led us to do is to speculate about whether the children might be actually performing different looking patterns when performing the static versus dynamic task, because that might explain the discrepancy for why they're essentially seeing the images as lower than available resolution, right? So when you see motion, you tend to have change your fixation patterns. The diagnostic information falls in the periphery, where you really process motion much better. When we see static images, we tend to foveate on the diagnostic cues, but it's possible that these children are not foveating and they're still using the looking patterns that they use when they see motion. And if that's the case, then the images are kind of falling on their periphery, and they would be seeing them at lower than available resolution. And so we're working on analyzing data to see if that's true, analyzing their eye tracking data to see if that's true. So let me skip over this. We looked at the pathways for these children relative to the expression recognition. But overall, we see that extended deprivation places significant limits on the development of basic facial expression recognition, although it doesn't completely preclude them. Extremely coarse vision during early development allows some minimal level of recognition to emerge, but this doesn't seem to provide a bootstrapping for later function. Only the most profound visual deprivation results in a dynamic advantage, and visual deprivation may result in a shift towards using lower than available spatial frequencies, which may be due or may stem from non-differential fixation patterns when looking at dynamic versus static faces. So the face individuation I wasn't going to present anyway. I have a really short video that you might want to see as a teaser just for why we look at face individuation. It's just a few seconds. Should I play that?
Yeah. Well, yeah, from my point, yeah, please do.
Okay. So this is again AL, the 7-year-old child. I'm showing here that we can look at her acuity progression following treatment at different time points. And we can also look at standardized assessments of face and object recognition. So these standardized assessments developed for children for positive prognosia. And this is just her data for the first 6 months. She continues to improve. And if I get a chance to present the face individuation at a future time, then you see that we kind of really consistently characterize these standardized assessments across children. And so let me just make sure. Oh, my volume is on. Okay, so this is a video taken about 40 minutes after the bandage was removed for this child, again, from the point of view of the eye tracker that she's wearing. And you can see her gaze in this video. So her mother is this one on the right.
अच्छा सुनीता मैम कहाँ है?
You can see that her mother is getting a little bit upset. She hasn't really said hi to the child yet. So you see that she really can't recognize her mother by vision immediately after treatment. But she is cooperative and understanding of the task, and you can see that she's looking and scanning the faces. And if we quantify her looking behavior, we do see that she's looking equally at both faces, not really able to differentiate between them until her mother talks, and then she really focuses on her mother's face. So we have this data for different time points and for the different children. And we're hoping, we've kind of already started to do this to contextualize it in the context of face identification and standardized assessments. So thank you to everybody. I probably am missing some people here. This is a huge collaborative effort. We have students, we have staff there and here, and of course, the families and the children that really enter our hearts. And we love these children. And that's it.
Sharon, thank you so much for a really exciting talk. I'm going to ask everybody to unmute yourself, and let's give Sharon a big applaud for really exciting presentation. And of course, I'm sure many people have questions, so I'm going to start. No, I mean,
sorry,
actually, I have.
I'm going to just stop this screen share because I mistakenly got out of this.
Sure. So
and at least I can see everything. Yep.
So I'm sure other people have questions, but so one note I want to say with respect to the color issue that you showed with the child mistaking the bottle for his friend. So I recall one of the papers reporting DF reported that basically she was able to, if I recall correctly, she was able to recognize a banana based on the color, and when the color was changed, she failed. So her visual agnosia was actually regardless of her color perception. So color can, I guess, guide. I mean, it's another very different example of how color can guide perception, even when it's in a way misleading. And another question, I mean, I've got many questions. I'll just pose one. So I was thinking, I mean, usually kids or children, infants have exposure to faces, and maybe even these children with very poor visual acuity, you know, devastating, because usually in their initial parts of their life, I don't know if that's the case also in India, but let's assume it's somewhat similar, that, you know, they're being held, they're being moved, they have faces, you know, with a giant visual field, and you know, very close proximity. And then when they start walking, basically faces get further away. I mean, smaller and further away. And their hands, on the other hand, which, you know, you said she had hands are always in their near vision, like their hands at least. So they are very they have a lot of experience, even if you think about their own hands. So I'm wondering if you think, just, you know, in a hypothetical aspect, if you think maybe this degradation in face perception relative to, you know, normative visual development has to do with the fact that they have missed, let's put it another way, if the faces that they have been experiencing until, let's say, the age of about 1 year old, have kept being very close to them, so very proximal, similar to the proximity of their own hands, do you think the trajectory would have been different? That's, yeah. I mean, I know it's, you know, it sounds absurd to have such social,
that's
social,
no,
but
I actually think that a lot of these, a lot of the like domain specificity, also in Margaret Livingston's data, is really rooted in a lot of socially kind of motivated visual experience, right? So I think that that's actually a really good point. Obviously, I can't answer that for sure. In terms of face detection, you can see from when the last video that I showed you, you can see that the child isn't looking everywhere. She's looking at the faces. She knows what the faces are, and she's jumping between the faces. So she knows kind of where this boundary of one face ends and another starts. So I think that that's very possible. I think that I know that you're familiar with the high initial acuity work that we published a few years ago. And this is the work that I didn't really get to present to you, but I already have the data analysis, and so I can tell you that, like, for face individuation, we're really seeing results that are very consistent with this idea of the high initial acuity, meaning that it really seems like it's a very true possibility that initially these children might also not be growing the receptive fields properly in order to do certain tasks. Maybe it's not non-face discrimination, but certainly like face identification that requires more extended spatial integration is not happening in these children, whereas the children that do have some pattern vision prior to treatment, like newborn or better, seem to be improving on both the faces and objects. So I don't know if that entirely answers your question, but I think it's a very good possibility. I'll tell you from anecdotal evidence that in the bandage removal, we kind of go through the whole thing, and we see all the kids really looking at the hands. And then when we're done, what we've noticed is that while the kids are waiting, a lot of them kind of look down at their hands and start to kind of, you know, so they definitely have a sense of their hands already. I think those that can finger count can see, and but yeah, they seem to be like interested in seeing it close up. Okay,
wonderful. Yeah, Udi, please.
Sharon, wonderful talk. I really enjoyed it. And but I had just one small question about this thing that you mentioned, that they look at the hands rather than the faces immediately after surgery. Because just before we had the break, now you showed this girl that seemed to do the opposite. When you asked her to identify the mother, first of all, she is looking upwards toward where the faces should be, right? So I'm wondering if it's task dependent, the fact that maybe automatically, as you say, they tend to look more at the hands but they certainly know where the face is supposed to be. From what you've shown, if this case is actually a characteristic case, so I'm just wondering about that. How characteristic is it that they actually look at their hands rather than looking at the faces, and is this task dependent?
So yeah, that's a really good question, and the reason we don't have this out yet is because we're really trying to quantify it in a consistent way. But I can tell you just from kind of being there and looking at the data, yeah, I think it's pretty characteristic. You look at a lot of the different videos, you see that they have not only this downward shift, but really looking at the hands. You see that they have that also a few days later. When you look like 6 months later, some of them really look at the faces and some of them still have this bias towards the hands. And I do think that it's task dependent. So what we see immediately after, yeah.
Just let me clarify. I mean, they do have nystagmus, right? So just to actually get the eye tracker and make sure that where they're looking, the calibration issue is really dramatic. So are you using a camera above the head, or are you actually using an eye tracker? Because
we're actually using an eye tracker. And so obviously the data that I showed you is for a child that we were able to do really nice calibration for. And she and her two siblings had really significant improvements in being able to control the eye movements. And so they had really beautiful eye tracking data after. That's very different for a lot of different kids. There's also misalignment. So, if they have strabismus, often we can't calibrate at all, or we can only calibrate after treatment. So that's where a lot of the difficulty comes in, and really like systematically characterizing this across different children, because we have different quality of data. But yeah, this is we were able to calibrate. We were doing this with a head-mounted kind of really high-end eye tracker that requires very little calibration. And we add some tasks to make sure that the child is really looking where we think they're looking. There's Bridget's lab has done, I think, some really nice work in being able to take into account the nystagmus and do calibration and look at looking patterns in these children in like computer-based tasks, which we've tried to do and I think have been less successful with. So I'm hoping that with the publication of her work, we can move forward with that. But this is more with when we look at these kind of naturalistic big settings where things are really nicely separated, so we don't need to have super high acuity with what they're looking at in order to be able to make some inferences. Yeah, but yeah, it is task dependent. So they know where the face is. They know to look at the face. And some of them, when asked about the face, will look up. Some of them will need to be told, look up at the face, and then they'll look. But a few months after treatment, when there's a face-related task, they will naturally look up. But if free viewing, less than controls.
Okay, can I continue?
Yeah.
I can.
Okay, thanks, Udi. So another question, I'm not sure, but probably you're familiar with Kalanit's studies about the cortical recycling and the issue that, let's say, resources that have been in ventral cortex that are dedicated to hands and body parts, and let's say probably arms and stuff, are then transferred to be directed towards text. So basically, more or less, areas that are foveated until before the age of the kids start to read, transform into being specialized for text, rather than other previous hypotheses that this is these resources were dedicated to faces. So it's body parts, or probably arms and hands would have a dominant portion in that. And also there are additional studies that show that children at this age change their looking behavior from being invested in looking at hands and shifting their gaze towards text and stuff like that. So I'm wondering, if this is the normative visual trajectory in looking patterns, despite the difficulties with the nystagmus and despite the, the inter-individual variability that there's enormous differences between individuals in the looking pattern. I wonder if you think that these children, the fact that they're looking at the hands, and is that something that maybe they are trying to, maybe there's some catch-up developmental trajectory that they're, trying to follow in a way, starting with the hands, then moving to faces. That's one possibility. And another possibility is, you said their head was, directed downwards in a way, which is both where their hands would mostly be, and their body would interact with the world. And also, we have found, we haven't published that yet, but we have found that if you look, definitely everybody understands that the lower visual space is closer to then, things that are further away. So maybe this is why they're, the fact that they didn't have decent visual acuity allowed them to look further beyond their very near space. Maybe that's why they're used to looking downwards to things that are really something that they can capture with their vision from before their operation. I'm just wondering.
Yeah, so I think there are different questions here, and I'll try.
Yeah,
hopefully
you don't have to answer
remember
any
all
of them.
No, it's okay. Just let me know if I forget anything. So first of all, in terms of them, their tendency to look downwards, I'm not 100% sure if they really tend to like shift, their head downward, especially pretty quickly once they start to have sight onset. So you see these, most of these children, even prior to treatment, like if we're standing in a group and one person kind of talks or laughs, then you kind of see that they shift their head and look appropriately toward where the voice is coming from. So I don't know that they're necessarily kind of keeping their head downwards. Actually, if they are, one of the things that I was really thinking about, and this might be more specific to children in India, is also, they have these like dresses that come down to where the feet are, and there's high contrast there, and you might get information about the posture. And so that also might be a reason why they're more looking down at the feet. But what we do see is that they definitely seem to identify right away and be interested in the hands, even when they're looking at them from pretty far away. So I don't know exactly how that would reconcile with this idea of just looking at their own hands. It's possible. It's also possible that they have just this kind of like high level information about hands. Hands are in movement a lot. They're easier to do,
Yes.
segmentation. They're important for what you're doing and for what other people are doing. And you kind of know how to locate them relative to the body because you're using your hands and you know where your hands are, right? So it could be any of those factors, and it could be a combination of those factors. Regarding yeah.
What you said about the motion, did you have some estimate as to the, just overall motion that the hands form in their visual field versus the motion that the face forms? I mean, probably the hands provide more contrast, or,
Yeah.
face motion is within a face, so maybe there's not so much contrast and it's more subtle than, hand on some, clothes or some background. So just wondering about that.
Yeah, well, we didn't. We could do that in our videos, but again, what we did was a more semi-controlled situation. And so we really had people stand still so that they couldn't extract other information when we asked them, like, which person is your mother? So I don't know that that is particularly informative, but we can maybe make some inferences based on like Linda Smith's work that I know she presented recently, looking at basically putting a camera on children, and looking developmentally at, how much they look at the hands versus the faces. And initially they look more at the faces, and then they kind of shift to the hands.
Yes.
So in terms of how it naturally occurs, I don't know if she ever looked at distances, though. That's a really good question, because obviously for our children, the statistics of the information of the visual world that they're getting might be different than toddlers up to adolescents because of their kind of very coarse vision prior to treatment. So I think that's a good question.
Yeah, definitely. I'm not sure Linda Smith actually presented eye tracking data more. I think it was just head mounted cameras.
Yeah.
So I'm not sure
Mounted
they have.
cameras, and she was looking at the image statistics of how
Yes,
much. Yeah.
precisely. So I'm not sure how much they have, eye tracking data and where the gaze is. Maybe they do and I'm mistaken, but definitely it would be really interesting to see differences.
Yeah.
And another question that I have, since Udi and Uri are here and they can provide some information about the Ethiopian project. So what Sharon said about the dress and the dress code or custom, is that similar in Ethiopia? So would you, or do you observe also the fact that, kids, when they tend to look downwards, or is it maybe?
I wouldn't say that that's a characteristic. Some of them, they would be looking sideways, and it could be, Sharon's nodding, so apparently she has the similar experience. Just an idea for you, Sharon, that came to my mind as I was listening to you. What would be interesting is, do they recognize the hands of others? I mean, the issue of hands is really, really intriguing because, I mean, think about my hands. There's so many degrees of freedom. And okay, recognizing your own hands is trivial, okay, because you know from proprioception where your hands are. But recognizing the hands of others, we may be competing on this, but this is something I'm telling you because I think it's really, really nice to try to look at this and to, if they can recognize others' hands, irrespective of the way the hands are seen, immediately after surgery. So if you get a chance to do that, that should be.
Yeah, I think that's really interesting, and I think again. In general, like working in face perception, as many other people have worked in face perception, I think there's been a very natural and good movement towards moving away just from thinking about faces to thinking about like whole person, right? So there's posture, there's movement, there's a lot of different information, and even in typical development, we can kind of break down and say, okay, this is the minimal information that people absolutely have to have. But in reality, in naturalistic life, people are probably using different information, whatever is most available to them. So I think that that's definitely the case in atypical visual development. And so, I am sure, or I would guess, that if they're asked to recognize their mother, and you saw that from Z, right? They're able to say, oh, that's my mother, but they might be recognizing them from how they move or from how they stand, or, there's like all kinds of information, or from their hands, if they're really used to like being close to them and interacting with them a lot. So there's a lot of different information that they can use. And I think the challenge is really breaking it down into, you also know that with these children, you kind of have to keep everything minimal. You can't put them through hours of tests. And so I think that's a really good question of, do they recognize people by hands? Do they recognize people by posture?
No, I meant, first of all, do they recognize the hands themselves? Okay, do they recognize hands as hands, irrespective of the posture that the hands are actually presented in? Okay.
Yeah, so I think they do. So again, not quantifying it, but looking at
immediately after surgery.
Immediately after surgery, we see that they have more of an interest in the hands, and we also had this part where they were holding the hands, and then people were going to show these like different shapes in their hand, and we asked them, look at the hands, and you see them immediately shifting to the hands to be able to look at them. So I do think that they know that the hands are there, and they see them. Yeah.
Okay. Okay. Could they actually mimic the hand posture that they see? That would be one.
That's a really good question that I would love to. Yeah. I mean, the imitation is. Yeah.
All right. I'm through.
Write it down.
Sharon, thank you very much. It was a really great talk, very exciting. I want to suggest to the two groups, Udi, I have to say you can think about collaboration and back-to-back ideas and not necessarily competition. Anyway.
Yeah, there's so many things to look at.
Yeah, definitely. It's very exciting.
No,
I mean, I think that would really be, a boost, even if it's two different viewpoints for the same, idea. So I really would, be joyful to see you both groups collaborate. But, I'm not, politics aside, So
Yeah,
Sharon, thank
no
you
need for
very
politics.
So really a great inspiring talk. Thanks for joining us and sharing. And I also want to say that next week we have probably the end of the series talk here with Mariam Vaziri Pashkam, who will speak about, she's from NIMH, and she will speak about vision for real-time interaction with objects and people, you know, just moving onwards in somewhat a similar direction, but, you know, I guess neurotypical development and probably neuroimaging stuff. So thanks again, and bye everybody. And thank you, Sharon,
Thank you
really
so
for a
much.
great talk.
Thank you.
Yeah, thank you.